In Chapter 20, we're going to look at the serological and molecular detection of bacterial infections. We'll start with looking at the immune defenses against bacteria, and you're going to see some review here, which is nice, and we'll mention the laboratory detection of bacterial infections, the clinical manifestations and lab detection of just a few specific bacterial infections, including group A strep, which is Streptococcus pyogenes, Helicobacter pylori, Mycoplasma pneumonia, and certain rickettsial infections. Bacterial virulence factors are something that should be familiar to you. The reason I have various weapons and methods on here is this is the way I think of the virulence factors. You know, the pathogens are the bad guys, and they have weapons. And there's a lot of different weapons that they possess. And over the millennia, as we have evolved and they have evolved, they develop their weapons. We develop countermeasures, and then they develop countermeasures for our countermeasures, and back and forth. So to me, it's like an ongoing war. You know, it's us in North Korea, sort of, where we just keep upping the ante and trying to protect ourselves. And in the search to protect ourselves, we come up with things that can do the other guy in. So things like capsules, which block phagocytosis and antibody attachment and complement activation. Fimbriae, those little tiny hairs, or sometimes they're in the form of little tubes that hook cells together. They also can contribute to resistance to phagocytosis. Certain adhesive surface molecules in the vein of, for a pathogen to cause an infection, it's got to land somewhere and be able to hang around, stick to those cells and tissues to be able to multiply and cause the infection. Flagella can serve as adhesive molecules, and then they also can serve to propel the pathogen away from our immune response. And then there's the exotoxins and the endotoxins. So as we run through these again, hopefully it's in your educational background. Now we can think of these virulence factors in terms of how they interact with different facets of our immune system. Speaking of countermeasures, what countermeasures is our immune system able to mount? Well, remember that intact skin and those mucosal surfaces forming a nice barrier, kind of like the wall around the fort to protect us. They produce defense chemicals that are antimicrobial, things like lysozyme, ribonucleases, defensins. These are molecules that are inherently antibacterial. Of course, we remember about the complement proteins, the cytokines, those acute phase reactants, things like C-reactive protein, etc. The recognition by the recognition of the pathogen associated molecular patterns by the pathogen receptor recognition units, and an example of those were the toll-like receptors. Then in our adaptive immune system, we have, of course, antibody production, the ability of complement to bind, which leads to opsonization and neutralization of toxins. And on the cell-mediated side, we have our CD4 T cells that produce inflammatory cytokines, and on it goes. So once again, weapons and countermeasures against those weapons. When it comes to diagnosing bacterial infection in the lab, for a number of decades now, the gold standard was to culture a specimen and grow the causative agent. This has been going on forever. In my day, this was it. This was the great way to do things. And in conjunction with that would be the microscopic examinations of the organism. Where we're going, probably very rapidly, is the direct detection of bacterial antigens. It's much faster, it's more sensitive, it's less labor intensive from the standpoint that when it comes to growing organisms and identifying them, that takes pretty highly trained people. Um, so I think this is where we're going. And this culturing of the causative agents might become a kind of a sidelight down the road, only used in cases where the other immunological methods don't apply. And then, of course, the big kahuna is going right in and detecting the DNA or the RNA of these organisms. Highly specific. Again, we're talking answers within hours rather than days, which was the case back when we were culturing these things, waiting for them to grow. And serology, of course, is the methodology used to detect antibodies to bacterial antigens. And then the next step is using serology to detect the bacterial antigens themselves. So we use serology to detect and confirm infections for which other laboratory methods are not available, to diagnose infections for which clinical symptoms are nonspecific. Current infection is represented by the presence of IgM, high IgG titer, or fourfold increase in antibody titer between acute and convalescent samples. If we want to determine whether someone has a current or maybe just a past exposure to a particular antigen, we can detect IgM levels and IgG levels to that pathogen. And if it's an old exposure, they're likely to have very low to no IgM, but have a high IgG titer. And then lastly, we can use titers to assess reactivation or re-exposure. Generally, what will happen is if a person has been previously exposed and we think they've been exposed again, we can run an acute and convalescent IgG, and the convalescent specimen collected a couple of weeks after the acute illness should have a greatly increased IgG titer in response to the re-exposure. Disadvantages of serology is that it takes a while to develop those antibodies. And so often when we were using these acute and convalescent titers extensively, well, they were kind of an after the fact thing because by the time you drew the convalescent titer, 2 to 3 weeks after the acute illness, they were better. And so it was a way for the doc to go back in the chart and say, oh, yes, I think this is what the patient was infected with. It didn't help them at the time in terms of choosing treatment or anything. And there's many immunosuppressed patients in the world today for one reason or another. And so, of course, measuring their antibody levels by definition isn't going to help you in diagnosis. Our old friend Streptococcus pyogenes, or group A strep. These are gram-positive cocci in pairs and or chains, spread by person-to-person contact, treated with antibiotics. Various infections that are caused by this organism include good old strep throat, impetigo, scarlet fever, toxic shock syndrome, and necrotizing fasciitis. This picture here is the necrotizing fasciitis. It looks like that's a forearm. If you haven't seen pictures of this previously, they're pretty gruesome, and I deliberately did not pick the worst one available to me. yeah, it's a wicked scenario. Now, multiple organisms cause necrotizing fasciitis. I want to make that clear because the public assumes it's caused by one thing. It's actually caused by a number of different species of bacteria. But what happens is, this particular strain of this organism is so virulent and it's producing so many toxins to such a volume that it's killing tissue very rapidly. And when typically the only cure for this is to amputate the affected limb because this infection is going to keep crawling up the arm or up the leg or whatever the case may be. And very, very gruesome. When infections with group A strep aren't treated rapidly or effectively, there's a couple of streptococcal sequelae that can occur. Sequelae is sequel, basically, and it's something that occurs after the primary infection is gone, and both of these do involve the immune system. So one is acute rheumatic fever, which can develop a couple, 3 weeks after pharyngitis or tonsillitis. Symptoms are fever, joint pain, and heart inflammation. This is thought to be caused by immune response to streptococcal antigens that cross-react with human heart tissue. So in other words, the infection has gone on for a while, and so a really strong high titer antibody response has been generated, and unfortunately, those antibodies are able to cross-react with heart tissue. The other type is post-streptococcal glomerulonephritis, excuse me. This involves the kidneys, whereby immune complexes are deposited. They kind of get stuck, if you will, in the renal glomeruli and clog it up. And so it damages the glomeruli, leading to urinary results: proteinuria, hematuria, edema, hypertension, etc. Now, both of these are a lot less common than they were, say, 50 or 60 years ago. And what made the difference is the discovery of antibiotics. Of course, this organism has been around for millennia, and so people got strep infections in the past, but they didn't have a way to treat them. And so generally these infections tended to go on for a while as the person's immune system mounted a response. And, as the ensuing battle played out, if the immune system won, then the person recovered and got better. The problem is those antibodies that were produced can cause long-term issues. In today's world, for most of us, any hint of a strep infection, we are probably going to seek medical care. And if we are found to have a strep infection, we'll be treated, and the infection will be cleared within a couple of days. And so getting to the organism early on seems to be the key in preventing these long-term sequelae. So they're still around, but not to the level they were many years ago. When I was young, I can think of a couple of family friends who were older, who did indeed deal with rheumatic fever. In terms of diagnosing these strep infections, we still do an awful lot of throat cultures, plating on blood agar, looking for the characteristic beta hemolysis, and testing for the organism that way. Still kind of the gold standard in a lot of ways, but it still usually takes at least 24 hours to get a positive result. So for a number of years now, we've had these rapid strep tests, which are using immunological test principles to detect the antigens of the group A strep. And so on the right is one manufacturer's version of that. There are any number of them available and in use in the clinical lab. I have wondered for years why this has not yet become an over-the-counter test. I know when my kids were young, I had the advantage of taking a swab and taking it to work at the lab and running a strep test, but people that don't have that advantage had to make a doctor's appointment and take the kid in and yada, yada, yada. So anyway, oh, and by the way, running tests on your kids and your family and yourself was very legitimate back in the old day. In fact, it was an acknowledged and encouraged perk of working in the lab that everybody in your family was fair game and yourself. And if you want to run a test, run a test, even to the point of if it was let's say it was a send out test, that all you did was process and send it out. Even those were complimentary. So it was kind of interesting in those days. You could check various levels of this and that on yourself or your spouse or your kids, and everybody said, "Oh yeah, that's a good thing." Of course, that changed dramatically in the 80s when DRGs came online, and now it is absolutely forbidden to run any test on anyone without a bona fide physician's order. The tests on this slide formerly were run much more frequently than they are now. Why? Because there was more sequelae floating around in the population before, but these are still fairly common lab tests. The anti-streptolysin O currently uses nephelometry, and this is used as a screening test for acute rheumatic fever, where we are testing for streptolysin antigen. Streptolysin is one of the products of Streptococcus pyogenes. Anti-DNase B is produced by both rheumatic fever and impetigo patients, so we can use it for diagnosing rheumatic fever and impetigo. We use enzyme immunoassay and nephelometry for that. The streptozyme test detects antibodies to 5 different streptococcal products, so it's kind of like an all-in-one. It's a batch test. You're testing for all of these at one time. The products or the antibodies to the products that it tests for are the ASO, anti-hyaluronidase, anti-streptokinase, anti-NAD, and anti-DNase B. Moving on to the bacterial pathogen Helicobacter pylori. This is a gram-negative microaerophilic spiral bacterium. It is the major cause of gastric and duodenal ulcers. The history is interesting, at least to me, because I kind of spanned the breakthrough on H. pylori. Before the 1980s or so, if a person developed an ulcer, they were told, try to reduce your stress, don't eat so much spicy food, steer clear of the caffeine, and that was about it. The dietary modifications and maybe some lifestyle modifications, because they thought that the stress and the acidity was the big contributing factor to these ulcers. Then, all of a sudden, a discovery was made that ulcers, in almost all cases, are caused by this particular bacterium. His particular virulence factor is that he produces copious amounts of the enzyme urease. And so what he does is kind of burrow into the mucosa of their stomach or the duodenum and produces this urease, which counteracts the acidity in the environment and allows him to live. Experts think an awful lot of us actually have this guy in our gut, and I think they're still working on why only some people develop ulcers. But as he burrows down through the mucosa and into the tissues below, that's the formation of the ulcer. So suddenly, same disorder, but we went from telling people to change their diet and their lifestyle to giving them antibiotics in anti-ulcer medications, things like good old Pepto-Bismol and things like that. And suddenly we were curing things that were formerly pretty much chronic conditions. Besides the discomfort and the other signs and symptoms from having these ulcers, they can lead to gastric cancer or mucosa-associated lymphoid tumors. So what a wonderful thing that now we can actually get rid of this organism in individuals that have developed the ulcer. My first experience with testing for H. pylori was in about 1983 with the CLO test. And the CLO test, this is basically about the size of a microscope slide. And in the middle of this piece of plastic, there was a molded well. And in the well, there was some agar. Basically, all we were doing on this organism was a urease test. And so via endoscopy, they would collect a specimen, inoculate this little area, send it down to the lab. Well, to give you an example of how powerful and how copious the urease is that's produced by these organisms, usually they would be positive by the time they got to the lab or within an hour or so of being placed in the incubator. So we used to kind of shake our heads a little bit thinking, this really doesn't have to be a lab test, because sometimes when they put it in our hand, it's already positive. Well, when we went a little further, we figured out that because of the urease produced by these individuals, we could actually test their breath. They were exhaling it. And so that was certainly an improvement over having to have an endoscopy. And of course, the breath tests don't come to the lab either, so you kind of take the lab out of the formula. And then we can use our immunologic test methods for testing for the antigens or the antibodies using ELISA. We can test for IgG in the serum. We can do sequential titers to monitor the efficacy of treatment. Mycoplasma pneumoniae. For a long time, they couldn't figure out if this was a bacterium or what, but eventually they realized that yes, it's a little tiny bacterium, but it doesn't have a cell wall. It's a big cause of respiratory infections, and the classic infection leads to something called walking pneumonia. The name walking pneumonia refers to the fact that when you have this isn't the kind of pneumonia that's going to knock you flat, and send you to bed. You feel pretty good. I had this years ago, and I didn't miss any work. I didn't feel particularly bad, but I coughed and coughed and coughed. I drove my coworkers nuts with all the coughing till they finally insisted that I run a cold agglutinin on myself and make a doctor's appointment and get treated for it. I think in those days the treatment was erythromycin. Don't quote me on that. I'm reaching far back into my brain for that. Mycoplasma pneumonia is also implicated in something called Raynaud's syndrome, having to do with impaired circulation to the fingertips. Not that uncommon, where people actually, their fingertips and sometimes their hands actually turn blue from the cold, from the lack of circulation, and that may occur on a 90-degree day in August. I had a colleague that developed it, and she worked in the lab, and this was before the days of latex gloves. But so she worked in knit gloves, winter type gloves all the time. Looking back, that's probably a nightmare in terms of potential spread of organisms as she worked the bench. But anyway, that's the way it was. It is spread by respiratory droplets. Until recently, we thought it could not be cultured. We have eventually developed culture techniques. I don't think you're going to see cultures done in the clinical lab at all. Far more commonly, we're going to test for antibodies to the organism, and again, we can test for either or probably both IgM and IgG to differentiate between a current infection and a previous infection, reinfection, re-exposure. The cold agglutinin test used to be about the best thing that we had back in the day. Not specific, because people that don't have mycoplasma can, have a cold agglutinin, and only about 50% of the patients do have cold agglutinins. And the cold agglutinins, by definition, if we call something a cold agglutinin, it is most active at refrigerator or room temperature, and that at body temperature 37, it reverses. Today's world, we can use various molecular methods to detect pneumonia infection. Rickettsia are obligate intracellular gram-negative bacteria, another organism type that, for a long time they didn't know. Is it a bacterium? Is it not? Blah, blah. Two groups of illnesses are caused by rickettsia, the spotted fever group and the typhus group. These are transmitted by arthropods, typically ticks. And so the arthropod critter, as I like to refer to them, maybe a tick or a mite or a louse, has the organism and transfers it to a human when it bites them. Just as a side note, epidemic typhus, don't confuse it with typhoid fever. The public sometimes does think it's one and the same. They're completely different, but somewhere along the line, somebody thought typhoid fever as an illness resembled typhus, as in typhoid. Oid means resembling. So, but anyway, they're completely different infections, and you don't want to confuse them. Rocky Mountain spotted fever, depending on where you practice, may be a relatively common finding in your lab. Or you may be like me, who I've always worked in the Midwest, is not particularly prevalent in the Midwest. I've never seen, personally, a case of RMSF. The illness, RMSF, is caused by Rickettsia rickettsii, transmitted by 3 different species of ticks. Symptoms include headache, nausea, vomiting, diarrhea, skin rash, death. Diagnosed via the clinical presentation. I'm told the rash is somewhat characteristic. And of course, again, where the patient lives, where they might have visited in recent times, patient history becomes very important in these. We can diagnose them today by immunofluorescent assay. To summarize some of the major points in this chapter, we reviewed a little bit about bacterial virulence factors, those weapons that they have that allow them to cause disease, things like capsules, toxins, etc. We reconsidered the variety of host defenses that we have to fight against bacterial infection, such as our barrier protection and complement and cytokines, and of course in the adaptive defenses, our innate or our cell-mediated immunity and our antibody production. Now, when it comes to detecting bacterial infections in the lab, first and foremost, it was culture, which encompassed and included staining and microscopic observation. That, to some degree, has given away in recent years to rapid detection of bacterial antigens, often using ELISA methods. We also use serologic detection of antibodies. And, of course, in recent times, molecular detection of the bacterial nucleic acids. And this is the way everything is going. And I believe that in not too long, the old cultures may largely have gone by the wayside. Lancefield's group A streptococci are gram-positive bacteria most commonly cause acute infections of the upper respiratory tract and skin. Some of the people who are untreated can develop one of two sequelae, either acute rheumatic fever or glomerulonephritis. Laboratory diagnosis of acute streptococcal infections involves culture on sheep blood agar as well as the rapid assays. Just a note on the rapid assays, the sensitivity is about 95%. I think the specificity is about 99.9. It's about as specific as you can get. But because the sensitivity is great, but this is an organism that we do want to treat if it's there in order to prevent the sequelae. This is why, if you're working in a micro lab, hopefully your standard protocol is that a rapid strep test that is negative automatically reflexes to a culture just to catch those 5% or so that the rapid kit may have missed. The diagnosis of the sequelae requires serologic methods to detect antibodies to the various streptococcal antigens, which include the anti-streptolysin O and anti-DNase B, because with the sequelae, there's not going to be any signs or symptoms of infection. Then the streptozyme test is a rapid slide agglutination test that detects antibodies to 5 of the streptococcal products, including the ASO and the anti-DNase B. Helicobacter pylori is a gram-negative urease-producing bacterium that causes gastric and duodenal ulcers. Untreated infections with H. pylori can progress to gastric cancer and or mucosal tumors. H. pylori infection can be diagnosed by urease detection in stomach biopsy tissue, the urea breath test, or an ELISA to detect H. pylori antibodies. Serologic tests and antigen tests of stool samples can be used to determine if the bacteria have been eliminated after treatment. Mycoplasma pneumoniae is a tiny bacterium that lacks a cell wall. It's the major cause of respiratory infections such as walking pneumonia. Another older term that you might hear is primary atypical pneumonia. This phrasing is used sometimes to describe walking pneumonia or mycoplasma pneumonia. Main methods to detect M. pneumonia are serologic assays for antibodies to the organism, PCR to detect DNA from the bacterium, and we could use cold agglutinins, but they're only produced in about half of the patients. Rickettsia are obligate intracellular gram-negative bacteria that are transmitted by arthropods. 2 diseases caused by rickettsia are Rocky Mountain spotted fever and typhus. Laboratory diagnosis is accomplished via serologic testing for antibodies to rickettsia by immunofluorescent assay. I'm leaving you with a picture of the tick, the cartoon character. Not that he's particularly attractive, but he looks a whole lot better than actual ticks, which I personally find really icky. Bye-bye.